Thank you, Tim. So I'd like to start today's community of practice by acknowledging the traditional owners of the land that we meet on today and pay my respects to their elders past, present and emerging. And also today is about bringing all wisdom into the room, and I acknowledge other people watching. So first of all, if you could mute your microphone for the first part of today's session, that would be great. You have been sent pre-reading the cardiopulmonary guidelines document, and you've been sent this PowerPoint, which has had a couple of recent updates. So the PowerPoint is really meant as a post-event take-home as well as the guidelines document. So I'll just start by introducing our panel. And we have Robin Fowler, hi, who is a senior physio from the intensive care unit at Armadale Hospital. We have Anita Dinsdale, who is the senior community physiotherapist at Community Physio. Tim Newing, senior physiotherapist from Cardiovascular Health at Fiona Stanley. And Louise Camp, clinical nurse specialist from Black Swan Health. Hi. Now, we think that today's session will be one of many. We cannot address all the questions around cardiopulmonary exercise in 1 hour, as I'm sure you would know. We will have question time, so it will be either by unmuting your microphone, which should currently be muted, or by texting to 0403859662. So if you want to text through any questions during the session, it's 0403859662. Thank you. This session will be available as a video on the TRACS website post the event. So I'm going to hand you over in a moment to Robin. First of all, there is one really important thing about exercise, which is that all patients should have left hospital with a My Heart Monitor, which includes a fridge magnet, what to do if they have chest pain. There are guidelines for chronic heart failure and COPD action plans, which will be referred to throughout this session. And Robin is now going to speak about giving patients some ownership of their chronic disease. Thank you, Robin.
Thank you. Just briefly, I'm here not in my RCU role, but I've done pulmonary rehab and cardiac rehab and some research into pulmonary hypertension, so I'm here on that basis. So basically, from my experience in cardiac rehab, patients come to us looking for some support, and we can offer that to them. You can offer that to them because you know what they need to know. They often leave hospital with uncertainty about what they can do physically, and as you will hear today and as in the guidelines, patients who have been screened, and they'll be screened, and you've got a list of the contraindications and precautions with exercise in your guidelines, they can exercise. So that's what you need to say to them, and it will be safe for them to do that. And I'll talk about the simple principles behind that. So basically, cardiac rehab cardiopulmonary rehabilitation is about chronic disease management, and it's a long game. So we're looking for lasting change rather than we're trying to make them fit for over a period of an exercise program. And what I've always done is to actually try and set the programs up so the goals are to actually tell the patients and teach each patient that they can exercise, it's safe for them to do that they should exercise, and they should exercise for the rest of their lives, because that's where the health benefits come from, not from getting fit over a short period of time, but for repeatedly and continuously doing physical activity and exercise. Know how to exercise, so they need to learn during the program what it is that they need to do to exercise effectively and safely, and to know when not to exercise as well. And so that's another thing that they actually need to pick up during their program. And you can teach them that. You have everything that you need, your resources and your education to actually let you feel confident that you can do that for them. They will feel vulnerable having been discharged from hospital if they've had an acute event. So the chronic disease principles, management principles, I'm not going to go through. You'll have heard that with multiple disease processes. Long-term adherence is really important. Small steps in the right direction is important. And reminding the patients that they have a very low risk of an event during an exercise program, and keeping physically active is good for them and will reduce their risk of an event rather than increase it. And the other thing that I really want to point out that I want you to take home is that symptoms are really, really useful to guide the intensity of physical activity, and also about whether the patient's actually able to continue their exercise program. So paying attention to symptoms. So the simple principles for cardiac and respiratory conditions is to take the prescribed medications. So if the patients are prescribed beta blockers and ACE inhibitors and antiplatelet agents, they really should take them. Some of the cardiac medications are associated with symptoms, like beta blockers with fatigue. If they're having troubles with their symptoms and they want to stop their medications, they should talk to their doctor about their symptoms, because they can often be titrated or managed. And sometimes it's just a matter of them actually getting a bit of time for the medications to actually settle in terms of their symptoms. They should also follow the other instructions that they've been given, and they should know their instructions, and that's an important thing. So their action plan is really important. So things like having their GTN spray and using their fluid restriction guidelines is really important. And again, to symptoms, while not being obsessed by the symptoms, they should pay attention to symptoms. So some simple information there in the next dot points, which I won't go through, except that chest pain, unless it's been declared not of cardiac ischemic origin, is not a healthy thing to have. Dizziness is generally not a healthy symptom to have either. So they're the sorts of symptoms that are particularly troublesome. Breathlessness in terms of management and what it means. Breathlessness is a really common complaint with pulmonary disease, cardiac disease, pulmonary hypertension, and so the degree of breathlessness is the thing for people to pay attention to. But again, not to be obsessed by symptoms, to use them to guide their exercise training and their physical activity while they're doing it, and if they're getting into problems with symptoms at rest, or they're bothered to see their GP. And most importantly, people should take responsibility and ownership for their ongoing health and management. So coming to you is about you teaching them what they need to do to actually look after themselves in the long term. So in my sort of thinking, getting fit from doing an exercise program in cardiac or pulmonary rehab is really almost a side effect of the process. So they get fitter, but what they need to be doing is looking at the long-term, long game. And I should think the other thing that I want to always say to patients is don't worry about relapses in their exercise program. Back on the bike as soon as they find they've fallen off. Right.
Right. Do that. Thank you, Robert.
Just a little bit about complex patients. Is that, again, symptoms are useful, and I won't go through this if you've got any questions about this, but if you actually look at the primary cause of the patient's, or think about the possible primary cause of the patient's symptoms, such as breathlessness, whether it's likely to be related to their respiratory muscles screaming at them because they've got hyperinflation, or whether in fact it's their heart failure that's causing them to be breathless, helps to guide the symptom intensity and the intensity of exercise for them. So again, symptoms can be useful if you actually look at what's probably causing the symptoms. And if in doubt, call a friend. So if you actually have somebody who's complicated, I would strongly recommend that you actually call and talk to one of the people who can actually help you with that. Thank you. That's all I had to say.
Thank you, Robin. And you may notice that the first slide is a recent report from the Heart Foundation, which said that the risk of major cardiovascular complications is one event in 117,000 hours of supervised exercise. And for me, that certainly shows that exercise is medicine. It is not the opposite.
And it reduces risk.
Yes, definitely. So, Robin did speak a bit about breathlessness, and as we all know, no patient comes with only one condition. Most have many comorbidities. And there is a session on our website, on the TRACS website, which you can watch the video of the breathless patient, which was a discussion of a case study of someone who had a heart attack and COPD. I'm going to pass you now to Anita, who's going to speak to how to set up and deliver classes in the community.
Thanks, Helen. Thanks, Robin. I hope you can hear me, and I apologise if I start coughing during the programme. I'll try not to. So community physiotherapy has been running Phase 2 and Phase 3 combined pulmonary and cardiac rehab programmes in a community-based, non-medical facility for 13 years. So originally the programmes were set up with the help of Nola Chechens at Charles Gardner, and is based on the programme run there. Many of you will have heard of Nola and her colleague Sue, who have been decorated with an Order of Australia medal for their work in pulmonary rehab, so we're very lucky to have had their help and support. So the aim of my presentation is to use the CPS model as an example of how to combine pulmonary and cardiac rehab programs, how they can be run safely and effectively outside of tertiary hospital settings, that first slide is just really a revision slide just to define the phase. Oh, sorry, can you just go back to that one? Just to define the phases. Phase 1 is acute inpatient or acute phase rehab. We run the Phase 2, Phase 3, and Phase 2 is usually an 8-week for pulmonary and 6 to 8 week for cardiac rehab, twice a week program, either in a hospital or community non-medical facility, which is us. And the Phase 3 is a maintenance program, mostly for pulmonary rehab. The evidence for Phase 3 and cardiac rehab isn't as strong. And again, hospital, community or home gym. So we're the community part of that. All right, sorry, Helen. Yes, next slide. Yep. So just to give you a little picture of this is just an example of one of our venues. So we really are out there in a sports centre. We carry the equipment with us. We have 15 minutes to set up and 15 minutes to pack away. So our equipment is quite simple, as you can see in the picture. All the sports centres are manned, so we have a phone to call staff as backup, and a defibrillator is available if we need it. If anything goes wrong, it's basically an ambulance to hospital. So our patients are screened with the inclusion criteria, which you've all got in your supporting document. Having said that, over the time I've been working in this area, I've never had a serious incident and had to call an ambulance for anyone that's had a life-threatening problem. It's been things like blood pressure dropping and chest pain, and I think Louise will support that. It doesn't happen that often, and it's mostly actually the cardiacs that we have problems, not the respiratories, which is interesting. Okay, so you'll have the inclusion criteria in your document, so I won't go through the inclusion criteria. They're pretty much identical to what we use at Community Physio. So I was going to move on to the assessment part of it. So I've just put up slides which we can flick through very quickly, which you'll all be very familiar with. We do an initial phone screen that identifies and can identify some potential problems, and then a 1-hour face-to-face with the patient at the venue. Extensive subjective history, which is usually in addition to what we've received from discharge summary. Most respiratory patients have a discharge 6-minute walk test, which has been sent to us, and usually a discharge summary, but sometimes they come through clinic and we don't have that. With cardiac patients, we usually get a discharge summary, but no 6-minute walk test. So the 6-minute walk test done in hospital in the acute setting can help us to predict if they're likely to desaturate. Objective measures, so blood pressure, heart rate and rhythm, resting saturation, weight and height for BMI, hip-to-weight measurement for the cardiac, and then I'll go on to the 6-minute walk test slide. So we can just really flick through those slides fairly quickly, and we might come back to them. These will all be sent to you, and I think you'll probably have access to them anyway. So what I really want to talk to you a little bit about is the 6-minute walk test. We're very lucky to be sharing the protocol, which has been adapted from Sir Charles Gardner Hospital physio guidelines. It's based on the European Respiratory Society and American Thoracic Society technical standards for field walking in chronic respiratory disease, and the guidelines we use for cardiac rehab are the same. So I just wanted to emphasise how important it is to standardise your 6-minute walk test in order to evaluate the effectiveness of treatment over time. The 6-minute walk test is very highly sensitive to changes in methodology. So, for example, the length of the walk track, use of a four-wheeled walker, and also instructions. So if the same instructions are used pre and post, and also used across sites, it means we can obviously collect data and attribute the improvement to the program. But you can't compare the data if the methodology is different. I also want to emphasise the learning effects in pulmonary rehab that's been very well researched, and it's very important to do 2 6-minute walk tests if possible. So if you look at the guidelines, I'm not sure whether it's this one or the next one, it actually it gives the, no, you can go back to it, gives the reasons why you wouldn't do the 2 6-minute walk tests, yes, so you have to read through it, sorry. The reasons why you wouldn't do the 2 6-minute walk tests with people. Most of our patients have already had one in hospital, so we're quite lucky we don't often need to do 2. There has been shown in research that there can be a 24 to 29 metre improvement in the second 6-minute walk test. So if you're repeating your 6-minute walk test at the end of the programme and you haven't done 2 at the start, it's very difficult to actually report a clinical improvement because of the significant learned effect. Minimum important difference is 30 metres or 10% of the improvement, which we can report as significant. We also recommend the use, and the guidelines recommend using a polar monitor because this helps to eliminate motion artifact on the oximeter. With pulmonaries, we do continuous oxygen monitoring, and this can help to identify exercise-induced desaturation, and as part of the guideline. We also look at other limiting factors, so breathlessness, pain, fatigue, and mark that down as a predictor of how they might do, whether they might need interval training in the exercise program. They recommend 30-minute rest between tests for pulmonary rehab, so during that time we do our quality of life questionnaire. For pulmonary, it's the MMRC CAT score, chronic respiratory questionnaire, and we also talk about functional goals. For cardiac patients, we use the SF-36 New York Heart Association classification and the Borg scale. So I don't think we need to go back to those because I think we've probably all got those. Cool. With repeat 6-minute walk test, if somebody's done less than 350 metres and breathlessness their limiting factor, we'll try the second test with a four-wheel walker to see if that makes any difference. And then you can use your 6-minute walk test to calculate your 20-minute walk distance and 30-minute walk distance. And I don't know if you know, I'm sure you all know the calculations for that, but we can send that through if you don't know that. You can use the 6-minute walk test with respiratory patients to predict whether they might need to interval train based on desaturation and resaturation time as well, to predict how long they might need to rest for, and that's all covered in the 6-minute walk test guidelines. So just the program descriptions, that's been very well covered by your guidelines that you've been sent. We also do encourage self-recording of values and get the patient to report any deviation from the norm. Recording's done in pen, not pencil, as per health department guidelines. And we encourage patients to progress their program according to symptoms, so you might increase the walk duration from 20 minutes to 25, aiming for 30-minute max just because of the time limitations. Duration speeds, rest times, reduce their intervals as they progress. With the exercises that are in your booklet, we don't use the broomstick exercise anymore, we do an upright row instead. After the third session, we give our patients a home exercise program, so we do like to encourage them to engage in the regular walking program first, and also work out if there's been any adverse reaction to the exercise they've been given. So our cardiac rehab, I don't know, we can't be seen, can we?
No, not at this point.
So we've got a cardiac rehabilitation exercise program and one for the respiratory, which we've been very kindly allowed to use the publication put out by Charles Gardner Hospital, which is a nice glossy document. It covers education, has all the exercises and also a diary, and Nola says that she's very happy if you want to cover the cost of printing, you can purchase that from her. I can also send a copy of ours through if it's something you're interested in, if you haven't already adapted your own. Education part of the program is also well covered by the document you've received. A couple of extra ones though for pulmonary rehab will be how the lungs work, lung disease, managing lung conditions, signs and symptoms of infection and exacerbation, importance of physical activity and home exercise program, causes of breathlessness, strategies to relieve, relevance of saturation and heart rate, communication with a health provider, oxygen therapy and other topics like osteoporosis and pelvic floor. Reassessments on completion of the program, and then we look at, repeat our objective measures and look at discharge options. So that's most of what I have to say. There are lots of fantastic resources on which you've also got referenced in your document. I will encourage you to look at any documents published by Sue and Nola. We're very lucky to have very well decorated experts in WA, and also COPDX and pulmonary rehab toolkit are fantastic. There is a course coming up which Sue and Nola are going to be running, I think, at the end of this year or maybe next year, for pulmonary rehab, physios that want to run pulmonary rehab programs, so get in contact with them if you're interested.
Good. Thank you, Anita. As Anita said, and I'll just quickly go through, there are many, many guidelines, and Heart Online is an especially good resource to go to for cardiac rehab and heart failure management documents specific to exercise. These are just some of the items to do with exercise that have really good documentation. And there's documentation for post-open heart surgery, for people with all different cardiac conditions. So we will be happy if there's any documents that you are unable to access, like the one that Anita's just spoken about. We are most happy to send you the how to get those documents post this event. I'll pass you now to Tim from Fiona Stanley. Thanks.
Hi everyone. Thanks, Helen. I definitely echo all the things that have been said so far. Just a little bit about where I sit in terms of what I do day to day. So cardiac rehab at Fiona Stanley is 5 days a week. We see 35 to 40 patients through each day through our gym, through 4 classes. So that's what I do Monday through Friday. And I've spent a little bit of time doing some pulmonary stuff at Freo in years gone by. I was asked to talk to you guys today from a couple of questions about specifics of exercise and what might happen in classes and how you might react to those different things across a couple of different topics. And the first one was exercise and blood pressure. I suppose the first slide of the presentation today on the 117,000 hours per event is, I think, really significant, a definite take-home message. I think for exercise testing that doctors and exercise physiologists do, the stats are about per 70,000 tests. There is a significant event, and that is for tests where we are exercising, where they are exercising people as hard as they can until they need to stop.
Yep.
And the stats are still 1 in 70,000 cause a significant significant event. So I think that's really take home that this patient population and the pulmonary patient population are actually pretty safe groups of people to work with. And one of the biggest mistakes sometimes we make is not working them perhaps as much as we could, and in that way we lose a bit of engagement. So look, the first topic with the slide is really about the blood pressure. So there's guidelines about when you should and when you shouldn't exercise people. It gets a little bit greyer as to when to be careful or when to be cautious and when to sit and make them rest. So I've written down what we go through in our gym, and they're based on some pretty robust guidelines. So for patients who have a 20-point shift in their blood pressure is normally when we sit and take stock of them. So if you've got patients coming through with a 20-point shift, that's when I would we would normally make them sit and wait and assess if that recovers. If they are starting from a low base, so if their resting blood pressure, if they're a heart failure patient, sits below 100, then we might look at a 10-point shift being significant there rather than the 20-point shift. The 160 and above of systolic, and the below the 100 is where we look at them and scrutinise them more closely and check their symptoms to see if they're symptomatic, but we proceed with caution with those levels. And the below point, the 180 and the 90 and above 110 are the diastolic or the contraindications. There are other conditions where you need to be a bit more cautious, and that's, I guess, just coming back to knowing your patient group. And examples of those are like aortic stenosis patients or patients following Bentals where they've had an aortic root repair or a repair of a vascular structure. Whenever we touch base with the consultants, and it's normally consultant-based here, and they have slightly differing opinions, but if you do get one of these patients come through, then it is about that 150 millimetre mark of pressure that they normally are cautious for those patients. I definitely want to acknowledge, I'm working 5 days a week in the tertiary centre, and you guys are likely to be seeing people maybe a step further along than when I see them, but you're also definitely going to get those patients which stay in the metro area before they're cleared for home after 2 weeks. And you guys might be the first therapist seeing them to talk about their exercise. So you can definitely have people walking through the door 4 weeks post their procedure, just the same as we can. And so these guidelines are, I suppose, useful for that. Warm up and cool down for blood pressure, really important in preventing larger shifts. So if someone goes from doing something really quite hard to plonking down in the chair and resting and recovering, the next 5 to 10 minutes they will have a much larger shift and be much more likely to feel symptomatic than if they do a gentle cool down before they stop and rest. So that's a really important one to also help your patients adhere to.
Yep.
Heart rate wise, look, heart rate is a tricky one because for your cardiac patients and a lot of the pulmonary patients, a vast majority of people walking through the door are on medications that warp the rate and change the rate in an effort to keep your heart in a steady state of relaxed and reduce it racing away and requiring more oxygen and those kind of things. So if anyone's on beta blockers, then you need to take the 220 minus your age with a bit of a pinch of salt. Okay, so, but with exercise, what most of the cardiologists and the surgeons would say to us and what the guidelines say is you can normally work to 220 minus your age, and then to 85% of that is the safe upper limit of the max. That's not on a beta blocker. There is another method, and the slide after this is the Carbonin or Carbonin method. That's a really nice one because it does take your resting heart rate into account. Okay, so it's your maximum heart rate minus your resting heart rate, times that by 70%, and then you actually add back on your resting heart rate to it. So it just puts your resting heart rate back into it. There's a worked example on the next slide, and it does show the difference in the allowable maxes on using the Carbonin method for different resting heart rates versus the 220 minus your age. So if someone's got a really low resting heart rate, then it's likely their heart rate max should be a bit lower. If someone's got a much higher resting heart rate, 90, then they should be allowed to go a bit higher. If a stress test is done, then that's normally their heart rate max, then you can work to 85% of that. Beta blocker therapy, the rough guidelines, and they are exactly that. Everything that you read is a guideline, and you to use your judgment and your training to decide how closely you stick to those guidelines, is that heart rate max plus about the 40 beats a minute. Okay? We often get patients sitting 50 or 60 beats above their resting heart rate on a beta blocker. They're feeling great, they're feeling well, they're engaged with what they're doing. Do we stop them? We don't stop them. We allow them to keep going.
Yep.
So that's the precaution. Yeah, jump to the next slide. That's just the worked example of the Cavona method. So I'll leave that there. You guys can have a read of it. It is useful if someone has quite a high or quite a low resting heart rate in terms of differing from that 220 minus your age and the allowable limit. You can see there the allowable limit on 220 minus your age for that patient is 112, okay, for 70% of the max, and if you use the Cavona method for that patient number 1, it's 139, patient number 2, it's 129. So quite a significant difference in what you'd be sitting there going, yep, that's all fine and all normal, okay?
Yep.
Pacemakers and ICDs we see a lot of, and you guys would see a lot of as well. Out there, I'm sure there are patients which are coming through, and patients which are coming through not for heart stuff, but for other things, with these devices in as their past medical history too. So you talk to some of the surgeons and they say give it 2 days and then they can do what they want, but you talk to the ICD techs at our hospital who are the ones following a lot of these patients up, and they'd go nothing above the head for 2 weeks. Nothing weighted above the head for the first 4 weeks or further 2 weeks after that. And that's to protect where the wires, the CSID and the pouch site. In terms of operationally longer term with pacemakers and ICDs, it's, I suppose, just to have a bit of an understanding of how they work. Generally, if someone's pacing dependent, that is they're 100% paced and the pacemaker has a ramp function, then it is designed to ramp up as it senses movement or as it senses someone's breathing rate with the electrical impedance across the wires in the chest. So that comes into play if you're doing static exercises with patients in gyms and they're pacing dependent and 100% paced. Is that sometimes they might sit on a static bike and the bike doesn't recognise their exercise, and 7 minutes into it, it's still sitting exactly the same as the resting rate. Easily checked if you just check their pulse or pop a stats probe on them. And you can check that it's ramping up. But it is important because different ones do sense different things, and I reckon 30% of the patients come through with pacemakers. New pacemakers, we pop them on, it doesn't change when they're doing stuff. It just sits at rest, and they're just recruiting their stroke volume for increases in their output in that case. They're unable to recruit their heart rate to increase their output. For ICDs, just know their therapy range, know when it would decide to give therapy, and we sit 20 points below that. Okay, if you are getting patients and you don't know their ICD settings, you can contact the service that had referred the patients to you, or we're certainly happy to take calls for people who, I've got this patient, they came through you, I don't know what it is, and we can forward on that relevant information.
Good.
The last one was the young, fit and healthy patient, and engaging these patients, and that can be something that can be really challenging to do. I think again, it's to take each patient as an individual, and this young, fit, healthy patient, if you follow those heart rate guidelines as well as their exertional guidelines, they're going to give you really different maxes versus that other patient which is not nearly as fit. So it is to allow them to go up and towards those maximum levels if they are feeling fine otherwise with them, but to treat each of them on their individual merit. Sometimes if they are wanting to return, a common thing we get is patients who are younger wanting to return to competitive sport, wanting to return to contact sports or those kind of things, wanting to return to the pool and go swimming and all of that kind of stuff. That can be really hard to sign off on, and it is okay if you are not comfortable doing that to say no. Don't feel pressured that you need to sign off or hand over that you believe that that's safe to do. 65 to 85% of their heart rate max and should be around about the range that they're allowed to work to, but as I said, that's quite different. And in terms of their weights, a big mistake we sometimes make, and other programs I think make, and I definitely made when I was at Fremantle in years gone by, was I didn't allow patients enough progression with their weights, and I didn't start them on the heavy enough weights. So there's good literature out there that says you should be, every patient who gets the core components for cardiac rehab, the guideline says everyone should be doing a 1 rep max assessment during their cardiac rehab program, and that you should then train them at 55% of that, and by week 4 they should be progressing to 65% of that. So that's some reasonable guidelines to follow for those patients. The 36 Bethesda guidelines is an old document, but it is about 100 pages long, and it lists pretty much every single cardiac condition and guidelines on return to sport for all of them. So it is conservative, it is a conservative guideline, but it's a really nice, comprehensive guideline on what people can return to, depending on what they've got. So if you're not sure, then you can refer to that.
Good.
They might take no messages.
I know, so we might come back to Tim's take-home messages. Thank you, Tim. So Joanna Clark was going to speak to the self-management of people with heart failure. So really important about the daily monitoring and recording of weight, being familiar with your symptoms. So we're really back at the very beginning where Robin said, give the patients ownership. They know when they're a bit more short of breath. They know when they're carrying more weight. They know when their shoes don't fit, etc. So, you know, they should be the ones monitoring, and like they do in CPS and elsewhere, really important. And always ensure they get their flu vaccines and their pneumonia vax, because that can actually push someone with heart failure over the edge. The heart failure action plan has almost like a traffic light, but in different colours of orange as to when you would seek help. And so Charles Gardner have this home care plan where you put the fluid restriction you're on, you record your daily weights, your sodium restriction, when to contact your GP, so that etc. These are great, useful documents. So medication is really important in heart failure and for ACS patients. These medications are critical, and it's about us ensuring that people fully understand why to take this, so they can take ownership of using their medications properly. Sometimes they make people feel really unwell in the beginning, so it's about engaging with your patient to let them know, yes, this is short term, you will feel better soon. Yeah, and just checking in with them. Yeah, they slow the progression of disease and keep people out of hospital. This next slide just has the medications that people with heart failure would be on. It wasn't in your original slides, but it also includes medications to avoid. So I just thought it was important, and we can send it to you post. Lifestyle modification, definitely you've got to be looking after all your risk factors and working with your patients and their loved ones to make sure they are addressing any negatives with their lifestyle choices. Surgery and implantable defibrillators, Tim has alluded to, and transplants and etc. would be the treatment options for heart failure. But self-management is the most important. So I'll hand you over to Louise now from Black Swan.
Thank you, Helen. Thank you. So you can see there on your screen you've got a stepwise management of stable COPD. So this is just a snapshot of the COPDX guidelines, which is actually a massive document. So this will simplify things and is something that can be easily referred to. You'll see the top section is classified into mild, moderate and severe, and that's dependent on the patient's FEV1. So if you've got an FEV1 of 60 to 80%, it's classed as mild disease. 40 to 59% is moderate, and less than 40 is severe. So you can see underneath in the blue box, you've got non-pharmacological interventions. This is really important. There is a lot of things that can be done for patients and that they can be doing them for themselves. I think one of the main things that we need to be thinking about is education. I would say that probably more than 80% of patients I initially see do not understand their condition at all. And once we give them the tools and the understanding, then they can be a lot more compliant and understanding of why they need to do certain things. Okay, so in that non-pharmacological intervention, it incorporates smoking cessation, which can be a very tricky one. We've talked about flu and pneumonia vaccines, but again, they are recommended. Optimising function, so again, we've already talked about pulmonary rehab, but that is one of the main things that will make a difference to patients with COPD. It's quite a frightening experience for people. They progressively become breathless and they progressively become more deconditioned. And because it's a horrible sensation, the breathlessness, gradually they'll stop being able to do basic activities if they don't exercise. So it really is important that we give them the reassurance that exercise is something that they need to be doing to keep their skeletal muscle function optimised. There are a number of comorbidities, obviously as with any conditions, but ones that you want to consider are cardiovascular disease. Anxiety and depression are huge with people with respiratory disease. So if we're not addressing that side of things, then they're going to find general condition management, whatever that might be, difficult. So it's quite important to address any anxiety and depression issues. Osteoporosis, if patients are having frequent steroids, then they are at risk of osteoporosis as well. And then oxygen therapy, bronchoscopic interventions. Okay, so in the bottom box you can see in the orange there pharmacological interventions, which I'll come on to in a sec. Okay, we can just go on to the next slide. No, all right. So this just talks, I've spoken about education, smoking cessation. Sputum clearance is important as well. We do encourage action plans for patients that have frequent exacerbations, and that they are so important and so useful in helping patients understanding their condition. You have on the next page got a copy of an action plan, which we'll quickly refer to. So you can see on the top section in the green, that's where you would put the patient's usual medications. And then in the orange section, it's the intervention you want that person to take should they exacerbate. What we frequently see is that patients start to develop symptoms perhaps towards the end of the week and don't actually get follow-up with a medical practitioner until the following week, by which time they can be severely unwell or in hospital. And that also runs with it the risk of deterioration of lung function as well. So we really want to be encouraging these patients to be understanding their condition, knowing what their normal is, and treating those exacerbations in a timely way. The medication, so what they would usually do is have a standby script of antibiotics and or prednisolone. And this is something that's done in partnership with the GP. It's not something that they should really just be going off and completely managing on their own. They should be letting their GP know if they are unwell. And obviously the section at the bottom is if things deteriorate and they need to go to hospital. But these are very, very useful in helping patients understand their condition. So yeah, we'll just go back again. Inhaler technique. This is something that is really missed. It's been shown that about 94% of people aren't using their devices correctly. So obviously they're having suboptimal therapy. So rather than increasing medications, we should be going back to just checking technique first before that happens. And I think other studies have shown that over 80% of health professionals weren't sure. If you're not sure on how to use devices, jump onto the Asthma Council website. They have videos which can show you how to use all of the different devices. It's really important that it's something that's done frequently with patients. We've spoken about vaccinations, pulmonary rehab. I'm not sure if you have support groups in your area, but it can become a very socially isolating condition. So support groups really should be encouraged wherever possible. And the last part of this is really the advanced care planning. Again, not something that should just be left to end stage. If we can start bringing those conversations up earlier in the condition, I think it will become more of a normality. And within the advanced care plan, it talks about enduring power of guardianship. So these plans only come into play when a patient can't make decisions for themselves. So the enduring power of guardianship is when they appoint someone to make health choices. Enduring power of attorney is when they appoint someone to make financial choices, and then you've also got your advanced health directive, which is when the person may stipulate that they do or don't want CPR, for example. So they are quite important. The other thing we do say to patients is that if you are going to make one of these, please don't keep it in the drawer in the kitchen. Anyone involved in that person's care should really be having a copy. And that includes, I usually send one to medical records of each hospital where they frequently attend as well. So I haven't got a lot of time, so we'll just quickly whiz on to medications. We've spoken already, you can see there's a massive amount of inhaled medication there, and it can get very confusing for people. So we need to first of all, the condition needs to be confirmed, because if that person's got asthma, then we should be treating the asthma first. But this today is COPD, so we're just talking plain COPD. So you can see on the left-hand side you've got SABAs. This is short-acting beta agonists, and also incorporate short-acting muscarinic antagonists, which is basically Atrovent. So those medications come on very quickly, and they can last up to 4 hours. You then have long-acting. So the SABAs and the short-acting drugs would be the initial treatment. Then we'd be moving on to LAMAs, which is basically a long-acting type of Atrovent, and LABAs, which is a long-acting type of salbutamol drugs. So the Atrovents work by preventing the muscles from becoming tight, whereas the beta agonists actually relax that smooth muscle to help open it. So the aim there is for bronchodilation. And their long-acting medications last between 12 and 24 hours. You then move on to combination of LAMA and LABA, and that's in the past we used to have a LAMA and a LABA separately initially, but now if you need to jump up and increase treatment, you can go straight to dual therapy. So the guidelines have changed a while ago in that patients with COPD, if it's just COPD, should not be on an inhaled steroid unless their FEV1 is less than 50% and they've had more than 2 exacerbations in the previous 12 months. So if you've got patients with COPD, we really should be going and actually looking to see. We have been over-treating patients with inhaled steroids, so that really is something that needs to be addressed. It can actually increase the likelihood of pneumonia, so that's the reason there. And it's actually been found that the LABA-LAMA combination is more efficacious at preventing exacerbations. So hopefully that's given you a bit of an overview of the medications.
Yep.